go. Jerry, we ready?
Good on.
Okay. Well, welcome everybody. Good afternoon. My name is Tom Buchmueller. I teach here at Ross, and I'm a member of IHPI. And it's my pleasure to welcome you to the 2023 IHPI Director's Lecture. The topic we'll be discussing is a big one, the future of Medicare and healthcare reform. As you can see, the format's going to be a fireside chat featuring the IHPI director himself, John Ayanian, and our special guest, Mike Chernew. Mike is the Leonard D. Schaeffer Professor of Health Policy at Harvard Medical School. He is a leading expert on health insurance design and alternative payment models. And he's done seminal research on accountable care organizations and other strategies designed to improve value in the healthcare system. He is a founding editor of the American Journal of Managed Care, a former editor of the Journal of Health Economics, and he's won numerous awards for his research. A key part of IHPI's mission is to not only produce high-quality research, but to have that research inform health policy. And what's really impressive about Mike Chernew's career is that he's been both a superstar researcher and somebody who's had a big impact on health policy. He's currently the vice chair of the Massachusetts Health Connector Board, and over the years, he's been an expert advisor to CMS and Congressional Budget Office. And most relevant for today's discussion, he's currently the chair of the Medicare Payment Advisory Commission. One of the things that's always impressed me about Mike is how he can take difficult, complicated topics, which is basically anything in healthcare, and talk about them in a clear, intuitive way. In our microeconomics courses here in the MBA program, we emphasize the importance of thinking like an economist. And when I look at Mike's research and his contributions to health policy, I think they're great examples of the power of clear economic thinking. But unlike a lot of economists, Mike's also quite charming and fun to be around. So it's a great pleasure to welcome him back to Ann Arbor, and I'm looking forward to the conversation.
Thank you, Tom, and welcome everyone who's here with us in person at the Ross School of Business, and those of you joining on the live stream. We will have, as Tom said, a fireside chat here that will include me asking our colleague Mike Chernew questions about the future of healthcare reform and Medicare policy, as well as an opportunity for members of our audience here in person to ask questions. We'll start that about halfway through today's session. And for those of you on the live stream, you have the opportunity to pose questions through the Q&A function on your live stream, and we will be monitoring that. And one of my colleagues, Kara Gavin, from the IHPI staff, will be posing questions on your behalf. So welcome, Mike, and welcome back to the University of Michigan in Ann Arbor.
It is tremendous to be here. I spent a lot of time in Ann Arbor, and it's great to be here. And I've met a lot of people this morning. It's really an impressive group, so I could not be happier. And so, thank you.
You spent the first 15 years or so of your faculty career here on faculty at the School of Public Health.
Go Blue.
Yes. So Tom had mentioned your role as chair of the Medicare Payment Advisory Commission, or MedPAC. Before that, you were a member and a vice chair, so you've had a long term of service at different times on that commission. For those of us in our audience who may not be familiar with MedPAC, how are its members selected, and what's the charge to the commission from Congress? What is its role?
So the MedPAC commissioners are appointed by the General Accounting Office, the Solicitor General, in a very mysterious process that no one, myself included, fully understands. They are chosen for their expertise in healthcare delivery. So there's people that work for large delivery systems, a lot of physicians. There's some academics that study health policy in a range of ways, like myself. We advise Congress largely on how they should update payment to providers. So every March, including about a week ago, we released a report that advises Congress on how they should update the conversion factors for the many fee schedules that Medicare uses to pay sort of in traditional Medicare. And then in June, we'll have a report where there'll be recommendations about broader Medicare policy issues. So Medicare Advantage will be a big one and a bunch of others.
So you mentioned that report. In fact, I was just reading it earlier this week, the one that you put out. And This one contains information about how different parts of the healthcare system are doing financially. Hospitals, physicians, skilled nursing facilities, home health agencies, dialysis centers, the list goes on of how many ways that Medicare funds healthcare. How are these various groups of providers faring financially in the data that your commission reviewed?
So as a general rule, within any one of those categories, there's wide heterogeneity. And I think one of the core problems that the Medicare program faces is how to deal with that heterogeneity across providers. Some of the ones, post-acute providers, they're actually doing quite well on Medicare payments, but of course they serve other payers like Medicaid. So if you're a skilled nursing facility, for example, which has been we've had a very challenging time for a lot of providers. In fact, I'd probably be remiss if I didn't emphasize the importance of COVID, both in terms of the harm it's done to Medicare beneficiaries, but also the real challenges that the delivery system faced. And it's amazing the work the delivery system did in response to COVID. But that being said, the providers, hospitals, and physicians tend to be doing less well than maybe they had in the past, and the MedPAC recommendations suggest they get paid a little bit more than current law. The post-acute providers, and there's a lot of challenges that the post-acute providers face, but they tend to be very profitable from a Medicare point of view, so our recommendations have tended to be less generous to the post-acute providers. But I think overall, the delivery system is struggling with a lot of challenges. The inflation associated with workforce issues has been a big challenge for a lot of folks, how they manage post-COVID. It has not been an easy time for the delivery system, and it's hard to figure out exactly how to get the payment, and I would emphasize even more the payment models correct.
And during the first year of COVID, the federal government provided some supplemental payments to hospitals. Did the MedPAC report factor that in terms of that extra funding that they received?
They did. In fact, if I answered your question more straightforwardly, the providers sort of on average in general looked quite good. And again, in part because there was a lot of COVID relief funding. Our recommendations are always forward-looking. And so while that's taken into account, there's always this tension about trying to predict what's going to happen. We're making recommendations now for 2024. So what's going to happen in 2024 based on what we've seen happen in the past? And I think you all can ask questions and then I'll just turn them back to you, is no one is completely sure how the delivery system is going to come out of COVID. There's been a bunch of changes related to COVID, and we're still going to have to wait to see.
Still working through that. So sort of taking a step back, the bigger picture, what are some of the key Medicare policy issues you think should be addressed in the next few years by CMS and by Congress? And which of those do you think will be addressed?
So Medicare Advantage is number one. I'll say more about that later if you ask me, but Medicare Advantage is, I think, clearly the most important one. Workforce issues broadly, I think, is a really big deal that's going to have to be addressed. That includes, but is not limited to, graduate medical education and a bunch of things like that. There's a bunch of other things. They've done a lot on prescription drugs. I think they'll do a little bit more on prescription drugs. There's a lot going on in alternative payment models. It's not clear Congress has to act on alternative payment models, but I think the unfortunate news, and it's always challenging when you're being live streamed, you don't know how exactly it's going to go, but the healthcare system is largely about health. We have a healthcare system to take care of Americans and the people that are covered by Medicare. And the mission, you asked me the mission of the MedPAC. The mission is to advise Congress on policies related to Medicare program. And our overarching goal is to make sure that efficient providers of care have enough resources to make sure that Medicare beneficiaries have access to high quality care. That's the basis of what we do. And there's some very specific criteria we use. But underneath that, there's a bunch of things like transitioning to new payment models and making sure that you do a bunch of other small things that are important.
So you mentioned Medicare Advantage as one of the top issues that needs to be addressed. Can you take us sort of the next level down? What are some of the features of Medicare Advantage that need more attention?
Yeah. So Medicare Advantage is the program that allows private health plans to serve Medicare beneficiaries. And since its inception, the Medicare Advantage program has been paid more than it would cost to serve those beneficiaries had they been in fee-for-service. That added payment is part of it reflects the efficiency of the Medicare Advantage plans. Part of it reflects intentional decisions by policymakers to pay them more. For example, the way Medicare Advantage plans are paid in low spending fee-for-service counties, they get paid 115% of fee-for-service, and that moves down. So there's some explicit decisions about paying the plans more than fee-for-service, but that added payment and the efficiencies and any payments that they get through coding of disease, all of that flows through to added benefits to beneficiaries, and they've become essentially at a historic high. And I mentioned before that the purpose of the healthcare system was keeping people healthy, but the challenges faced by the healthcare system are largely financial. And so the key issue in Medicare Advantage is how do we preserve the access to better benefits that we really want the program to be able to provide at a fiscally sustainable rate? And that's where the tension is.
So we hear periodically about the Medicare Trust Fund, and what should we be thinking about in terms of policies to make it more sustainable in the long term if fiscal challenges are the biggest ones?
So first thing is I would probably ignore the trust fund. There's a trust fund. It's really part A. It's always going to go bankrupt 4 years from now, no matter when now is. That's not exactly right. I think I'm speaking a little glibly, but when the trust fund goes away, it is not like the Medicare program will go away, right? There'll be a transition to what happens to payments. And so the question ultimately is not so much about the trust fund, but more broadly, how do we finance care for our seniors? And and actually people with disabilities also have to work for Medicare. And the core problem is over time, like in 1970, there were roughly 5 workers per Medicare beneficiary. Now it's fallen to about 3. By 2040, it's going to be a little bit more than 2. And it turns out there's some very basic math, which is if you have fewer workers per Medicare beneficiary, the workers have to pay more to cover the Medicare beneficiaries. And that has a bunch of tax implications, which is problematic. Historically, what Medicare has done to become fiscally sustainable is they've taken money from providers in a bunch of ways. So they've taken, and pharma companies I would put in that category of providers. So they've gotten some funding from the drug companies through certain programs. They've done a lot to lower the payment rates for physicians and hospitals. Physicians in particular, a big challenge is going to be what to do with physician payment going forward. And so there's not a lot more money they can get from cutting those fee schedules. So they need to find ways to encourage more efficient care. And I do think they'll be able to take money from the Medicare Advantage program, although they'll lose some benefits. Mm-hmm. So I think those are the big challenges. How can they pay a sustainable rate to provide better care to more people with fewer workers?
A big challenge, yeah. So you talk about sort of changes to the Medicare program, one of which we've had over the past 10 years are the development of accountable care organizations, sort of authorized in the Affordable Care Act and then launched a few years later. What are some of the takeaways that you have about the successes and limitations of this model? And maybe you could sort of share for our audience, for some who may not be familiar with accountable care organizations, sort of what's different about them within the traditional part of the Medicare program.
So accountable care organizations were designed to be delivery system-based organizations that accept risk for an accountability for financial and clinical outcomes for their beneficiaries. And I think the original notion was you had all these health plan intermediaries, couldn't we cut them out and just give the money straight to the delivery system and let the delivery system become more efficient and keep those savings and share in those savings? So the main program is called the Medicare Shared Savings Program. My sort of one sentence takeaway is if someone offers you $1 and gives you a dime, take the dime. So, they were introduced with great fanfare. To give you some idea, the Medicare Advantage plans probably save 10-ish%, maybe a little less, maybe a little more than 10% of spend. And there was great fanfare that if you, and they siphoned some money away, that you could help the delivery system become more sustainable by giving the money to an accountable care organization. You have no plan siphoning off the money, and the providers could live on relatively low fee trajectories. And they saved 2%, 3% maybe. Depends how you measure them. I think, again, many people are quite disappointed by that. I think some of that reflects the design of the ACOs. I think the question going forward is, as Medicare Advantage grows, and Medicare Advantage is about half of the Medicare program now, we built a Medicare program around traditional Medicare with a small private set of plans. Now we have a program that's largely dominated and increasingly dominated by a bunch of plans, and then a relatively, the fee-for-service side is half. Of that fee-for-service side, a fair bit of that is the ACOs. So like in traditional Medicare, no one's at risk. That's actually now the minority of the Medicare program. And as more people move into Medicare Advantage, it's much harder for groups to take risk because you need population scale to take risk. And if you siphon those people into the Medicare Advantage programs, there's not enough people left to spread that risk in an ACO. And so I think the challenge is how you're going to balance that level of accountability. And I don't think we have an answer to that yet.
So when we think about, we're the Institute of Healthcare Policy and Innovation here at the University of Michigan. Many of our faculty are conducting research on Medicare, on healthy aging, on people with disabilities. What do you see as some of the big research questions that groups like ours, you and your colleagues at Harvard and others around the country sort of could be addressing to kind of help solve some of these challenges that you're describing?
So I spoke to a great group of people this morning in several different meetings, and I'll say one thing that's important is success hinges on being able to efficiently deliver care. So all the financing stuff, that's all enabling. What you really need to do is how to give people better care for less resources. That includes a lot of workforce things. How can you use physicians and nurses and other health professionals in a more efficient way? How can you use medications in a more efficient way? How can you so there's a ton of work on that. And I think that's sort of a first order question. I was talking to Eve Kerr about the administrative burden. One of the things I think policymakers do just a horrific job that drives everybody crazy is the administrative burdens of operating in this healthcare system are just crushing. When you hear what actually has to happen, it's almost mortifying. And so I think a lot of work on how to simplify the system ends up being really important. And then, of course, much of what I've done, and I think what many people that I know do, is they just do evaluative stuff. People do things, and then you figure out, did it work? Did it not work? I do think, while that's important, and I think correctly noted that was really much of my career, sometimes you put too much weight on evaluation in policy. Like there's something in Medicare now from the Affordable Care Act and CMS called the Center for Medicare and Medicaid Innovation, CMMI. And the rules are that they have to have evaluated savings, which seems like it makes sense. We don't want to do something that's going to spend money, but there's not enough humility in our ability to actually figure that out or acknowledge the uncertainty. So like it's been defined, you have to be 95% sure they save money. That's a hard bar to meet. And so I think any type of evaluative work to understand what's working and understanding how they work together, because we often evaluate these things like they're one at a time, but they work together. How they work together in a system, I think, is really important. And I think there's a lot of people in Michigan that are doing that type of evaluative work. And I want to say one other thing before you ask. I know you have another question. I know I'm talking too much. One of the core challenges for this entire transformation is measuring quality. And we struggle with this at MedPAC all the time. I think everybody struggles with this. It's very easy to say. I said it a little bit ago. I'm not ashamed. I'm mildly sheepish. We want to give people high quality care. That's so easy to say when you're sitting here in this nice auditorium talking to people. Like, what is that? How do you know if they're getting it? How do you measure it? How do you measure it in a way that doesn't drive all the people delivering care crazy because you're making sure they prove they're providing high quality? And so there's a lot of work going on in that space. And I don't think it's simply a question of, can I come up with a better quality measure? Everybody should have this done or that done. And since I can't pronounce most medical things, I won't. But in any case, I think it's much more about how do we think about the bigger system design things we should put in place to measure quality? Because I don't think there's enough understanding that getting to better quality is not simply a clinical exercise about measures. There's a bunch of statistical things around this. It's important. And I think, I'm going to say one thing because it's just fun to be here. So Tim Hofer's here. One of my favorite Tim papers, and Tim, I may get this wrong. You can stand up here. Because of the statistical properties of quality measurements, it turned out that many hospitals labeled good quality were actually bad quality because they were hiding, essentially. They were to hide because of small sample sizes. And actually, many of the ones labeled bad quality were actually good quality. They just got bad draws in the measurement system. And so we have this belief, did I get that loosely right? Loosely right. It's like you've lost everything since you left Ann Arbor. But the point remains, we sometimes believe we can measure quality and we get that measure of quality and that's like the number. And we don't appreciate the statistical properties of that quality measure and what it means and how we should react to it. And so I think there's a lot of work, not just on coming up with quality measures, but a lot of work on understanding the statistical properties of them and how to integrate them into our payment models and integrate them into our general policy environment.
Right. Another factor would be how stable they are over time.
Yeah, absolutely.
From year to year, they can vary just by random chance.
And how to risk adjust them.
So, well, let's shift gears. Something that's been in the news lately is the Inflation Reduction Act, and particularly the changes to Medicare and especially its ability to negotiate prices for a limited number of medications, which it's never been able to do in the past. What do you see as the implications of this new policy for beneficiaries, for pharmaceutical companies, for insurers providing Part D drug plans?
Yeah. So directionally, it's clear. Magnitude, it's not, right? So overall, the prices of drugs that have been launched, I think, will go down. Overall, the launch prices, I think, will go up. I think net we'll be spending less on drugs, depending on how it's implemented. And I think there'll be some impact on innovation. Maybe the amount of innovation, maybe the type of innovation. And depending on your view of industry and your view of innovation and your view of science, that could be very big, almost crushing, or it could be actually quite modest, and the companies will find a way to do the innovation and get us the drugs that we need. And again, a lot of the details of implementation are unknown, so it's not completely clear what's going to happen. There are parts of it that are to improve access to drugs. I spent a lot of time trying to make sure that people have access to imported medications. I think that the out-of-pocket prices that people pay, which is, I think, sort of the poster for what they really cared about, those actually will go down, particularly some of the big areas. So
Some of the higher costs.
some of the higher, well, insulin, again, it's $35 insulin, and now they're going to do separately co-pays for high-fi generic drugs. So there's a bunch of efforts to make sure that people don't face financial barriers to access their medications. That's different than making sure that the drug companies get less money. And of course, in our drug distribution system, we have an incredibly complicated interplay between the manufacturers, the distribution, the PBMs,
PBM standing for
pharmacy benefit management firms that manage all these rebates and formularies. We have created a very comprehensive healthcare system, but we've created a very complex healthcare system, and for a range of reasons. But sometimes you look at that complexity and you've just got to ask, there must be a better way.
So, and while we're on drugs, sort of what's your view now that we've had the Medicare Part D drug program for 17 years, I believe? How has it fared in terms of access to medications for Medicare beneficiaries? And the cost?
I think it's been a tremendous success. Well, what's happened, it's been a tremendous success for access to beneficiaries. What's happened is, because of the design of the program, a lot of the spending is in the catastrophic phase where Medicare pays the vast majority of the spending. And so it looks like it's been quite stable in terms of, if you use premiums, for example, it looks like it's quite stable. But drug spending has really been shifted to this catastrophic phase, and so it's risen quite a lot. And I think one of the challenges, which has been true since I started doing this years ago, is medical innovation broadly, we're talking about drugs now, offers tremendous promise. And again, there's nothing like the COVID vaccine to really illustrate how important drug innovation is. But apart from that, cancer drugs, I can't name enough conditions, so I'm really not qualified to speak medically. But almost every area that you've been, there's been tremendous drug innovation. And in many cases, again, when I started, it was like Park Davis over there. They were inventing Lipitor. It was super expensive, but then it became generic. We have access to really good medications now, really cheap, because they've gone through the patent cycle. But the challenge is financing all the new ones. And we want all the new ones, and I think we're struggling with the Alzheimer's drug was called Aduhelm. It worked very well, or so I'm told. And so CMS is limiting access to it. It would be wonderful, and just being a live stream, so I'll be careful. I'm on record. I would love a good drug for treating Alzheimer's. It's really, personal experience, really would be a tremendous success if we had a better drug for treating Alzheimer's. How we finance that what would we do to finance the innovation and then the access to it, is really a true challenge that I'm not sure we've completely grappled with as a country. So
shifting gears again, some of your work has been on alternative payment models in the state of Massachusetts. What are some of the lessons from that work, and what role can state-based reforms play in public and private insurance to improve our healthcare system?
So the Massachusetts thing was a private sector initiative, and one of the lessons is the private sector can design things quicker and I think in many ways better. And they did do, saved 10, 15% after 4 years. Now, because the private sector is more dysfunctional, about half of those savings were actually through shifting sites of care to just lower price sites of care as opposed to changing care. But I do think they were quite successful. And I think that AQC, which was the Blue Cross and Blue Shield of Massachusetts program, was the model for the ACOs in the Affordable Care Act. But there's a broader state policy issue, which is really important. There's some basic things, how you think about expanding Medicaid, how you think about the Medicaid program pays providers, how you regulate prices. There's a ton of interest now in states in terms of provider price regulation. And I think for a bunch of reasons, state policy will probably be the most important policy nexus. We've done the Inflation Reduction Act, we've done the Affordable Care Act, there'll be some Medicare reforms, but I think for really big health policy things, I think a lot of that's going to fall to state policymakers.
In Massachusetts, if I recall, about 10 years ago, created a costs commission and sort of a statewide set of policies to try and contain cost growth in Massachusetts. What's your view of that effort? From
Yes, I'd be careful because I like David Culler be watching me. It's the Health Policy Commission. My summary of it is the strategy they took was basically targets, hope, and shame. So they set targets, they hoped they were met, and if they weren't, they tried to shame people. You have to do performance improvement plans to get to it. And I think it's an ongoing question about whether or not it's been successful. We certainly still have fiscal challenges in Massachusetts, so we haven't solved the problem. But I think more broadly, you see a much stronger office in California. We'll have to see. That's too new to know what's going to happen. A lot of work going on in Oregon. Maryland has been the poster child. Maryland's been doing versions of this in different iterations for literally decades. And I think in the case of Maryland, and to some extent in California, it's a question of just controlling the price. And one thing Medicare does, Medicare controls the price. Medicare spending growth has been lower. Turns out if you pay less, you end up paying less. Not that deep. I mean, it's nice to be, looked to for advice, but the advice of pay less and you'll pay less is really just live by that.
Right, and so that creates a challenge for hospitals then charging higher rates to private insurers.
And right, so therein lies, I agree completely. So if you pay less, you will end up spending less in general. And the question is, how much does the delivery system really need? And we came from a sort of narrative historically about cost-based reimbursement, right, up through, when they started with DRGs. And that was a world in which the basic paradigm was the providers are going to deliver high quality care. The job of the payment system is to just give them enough money to provide that care. And it turns out that they would spend more and you would give them more, you'd spend more, and you give them more. And it wasn't as, the amount that they needed wasn't quite so fixed. And so we moved to models to try and incent more efficient care. And, again, we started in the 80s, so 40 years ago, roughly. And we're still at that same level. And it's funny because there's still in the narrative, and even though we have these other payment models, still in the narrative, a fundamental cost-based version of what's adequate payment. This is what we're spending. We need more money. And I think transitioning business models, since we're here at the business school, towards really focusing on more efficient delivery of care is important. And I think a lot of people are doing that. But there's also a lot of people just trying to figure out how to get more revenue.
When you talk about efficiency, is there anything that you see happening out in the healthcare system or the market that's sort of moving in that direction? Some ways that organizations are becoming more efficient?
Yeah, well, there's a ton of stuff that's going on that there's a lot of virtual care that could be used very efficiently. A lot of virtual care that also could lead to higher spending. So a lot of times it's what's the organization's incentives and what they're doing. There's a ton of my jokes. Ken's here. I'm just going to point out. There's a lot of post-acute care is the ATM of ACOs. So figuring out what to do on post-acute care and how you can manage the variation of post-acute care is, I think, one area where people are trying to become much more efficient. And again, I think I should say efficiency is not the same as cheaper. Efficiency is sort of providing good care, the same level of care for less, or better care for a little bit less, some version of that. And so post-acute is one area there's a ton of work being done. I think there's a lot of work on workforce that is going to be done. How you triage between nurse practitioners and physicians, and when you send people to specialists, how you use ED. I think there's a lot of we tried to get people to do less low-value care through the Choosing Wisely initiative, with an emphasis on the word tried. And I really commend them, at least of acknowledging there was low-value care. But I think a lot of it is just the blocking and tackling of how you move patients through the system in a way that requires less intensive, less invasive, and in some cases, the same thing, just cheaper care.
We're coming up on the 10th anniversary of the launch of the federal and state marketplaces. The federal level, it's known as healthcare.gov. I think 16 or so states run their own marketplaces. What's the impact been of that marketplace coverage, and what do you think it portends for the future, that part of the Affordable Care Act?
It might not be. I'm a huge fan of the marketplaces. I actually think state marketplaces have the potential to do better because, for example, in Massachusetts, we standardized the benefit package, which helps the shopping experience. We oversee it in ways that I think are really valuable. Cover California, same thing. So I think it's really valuable. And again, in Massachusetts, we have a very low uninsured rate. It's been invaluable for getting people access to care, and we have Massachusetts puts in a little money on top, but we have much more generous coverage for much more people, much more stable, and I think all the evidence suggests that certain things like expanding Medicaid, giving people coverage, is helpful for a range. You could have a long discussion about the evidence on that, but I think in general, Medicaid expansion and coverage overall, certainly it helps people's financial well-being and their mental health, and I think you could debate the healthcare evidence, but my read of the healthcare evidence is relatively positive in the grand scheme of things. So in that sense, it's been a success.
And another part of the Affordable Care Act was the expansion of Medicaid. You referenced that. We started with about 25 states expanding Medicaid. I now think we're coming close to 40. It looks like North Carolina may be the newest state to expand Medicaid sometime in the next year. What do you think the other remaining states, 10 or so states, will eventually expand Medicaid? Can the federal government do anything to
The key word's there, eventually, and so I'm going to go with yes. Eventually. It's like a Keynesian statement in the long run. So the ACA was set up to heavily incent the states to expand. It's been a very challenging thing to have happen. Not expanding Medicaid means those states are leaving a lot of money on the table. So as I've said, non-expansion states are subsidizing the people in Massachusetts, for which that's grateful. I think, I'll just speak for me, we would subsidize them if they want. If they don't, then we aren't subsidizing them. So it strikes me as internally a reasonable decision for states to expand Medicaid. And just to be clear, and I talked to everybody here, Helen's done work, I think with you actually, when they expand Medicaid, they get to tax the money that comes in, and it's not as expensive as they think it is because it just becomes a fiscal stimulus. And so that's a useful thing depending on how much fiscal stimulus you need. So I think that's true, but there's a lot of resistance. There's a really core, and we can talk about this later, I think there's a really core debate going on in this country about what the role of government should be in healthcare. Just a really fundamental question about the extent to which the government should be involved in the healthcare system. And if the government's involved, to what extent should that be the federal government or the state governments? And that's a really deeper question than just the fiscal parts about expanding Medicaid. So we'll have to see, because of the tensions in those states, about that type of role issue.
Great. So I think we're at the point of our program where we'd like to open the discussion up for questions from all of you here in our live audience, as well as those on the live stream. You have the opportunity to submit questions for Professor Chernew through the Q&A function in the live stream. And we have two of our IHPI staff colleagues with roving microphones. I see our first question here in the middle.
You can just shout. I'll shout your question out to the
microphone, though, helps for the live stream.
I'll shout them. They're all now covering their ears.
Hi, I'm Soumya Rangaraj, I'm a physician. I'm a geriatrician and hospitalist at Michigan Medicine. I'm also medical director of our hospital care at home program, which we've had up and running for about 2.5 years now. And one of the things that we've found interesting is we have been trying to admit patients, a relatively small number, but directly admit them to our program from home, where we bypass the emergency department, bypass the inpatient hospital completely. And it's actually been very successful, and the patients are happier with that. And I know my emergency medicine colleagues can speak to this, but we have a boarding crisis in the emergency department at Michigan Medicine and everywhere. So, but the problem is we don't have a payment mechanism through Medicare for this. We've actually mostly been doing this, as you mentioned, sometimes the private insurers are actually more nimble. So we've actually had some success getting the private insurers to kind of be on board with this type of direct admission process. So it seems like a win-win for everybody, but the problem is that the PHE didn't really allow that as part of the waiver, the CMS waiver. They always have to go through an inpatient hospital stay, and that has extended into the omnibus bill that has extended hospital care at home for 2 more years. And I'm trying to figure out a way to get this out to people who make these decisions. And writing letters to New England Journal or Journal of American Medical Association is great, but nobody's going to read those in Congress.
Well, that's not true, by the way, since speaking to an editor.
Okay.
But
yeah, but how do we get these to the people who can make these things happen?
Words, JAMA Health Forum. Yeah. But so let me just, I'm not sure there's a question, but that's not going to stop me. The problem with something like hospital at home, and you know a lot, I think it was David Silver did a lot of that in Boston. So and this is true for, there's a ton of stuff that fits into this exact same category into virtual care. If you take a person that would have gone to the hospital and you give them hospital at home, many people believe, and from your question I'll infer you do, that that's a win-win for everybody. It's cheaper, better, they like it, it frees up space in the hospital. Totally understand. The challenge is, and this is this exact same narrative happened with hospice. It happened with home care, where the narrative was, we're going to keep people out of the nursing home and we'll give them care at home and we'll save a lot of money. All the evaluations suggested that didn't happen. And the reason was because there were a lot of people that wouldn't have gone to the nursing home that ended up getting home care. And just as an aside, I'm a big fan of home care, right? So this is a narrower question about would it save money? And again, let me say, I don't believe saving money should be the be all and end all, but it is an important all in how we have this discussion. So the question ends up being, how do you make sure that when you open up a program like Hospital at Home, the people that you're putting in it are people that would have been admitted versus people that would not be admitted? And when you're on the ground and there's a particular person, it tends to be very clear to you. But when you're not, and you're worried about that, you worry about opening the floodgates, and you worry that the people that are doing it, for lack of a word, say pure of heart, are not the only people that will be doing it. And so you see this, I'm a big fan of virtual care and telehealth. I think many people would tell you, I would tell you, it's incredibly important. PHE aside, by the way, so just post-COVID, it's incredibly important and valuable for people to have access to care in a virtual way. The challenge is when you make that access easier, the people that are accessing care may have been people that otherwise wouldn't have. And some of that care would have been care they should have gotten and now they're getting. And so we should cheer that improved access. That's the point of improved access. But some of that care, maybe not so much. And so the easiest way to think about covered policies for hospital at home, and this is going to be a little naive, and I apologize given the sort of setting, but the easiest way to think about hospitals at home is go into a risk model, right? Take population-based risk, put in whatever program you want, and don't worry about what you're getting on the back end and the fee-for-service side for the admission. It is really this, you asked me about ACOs. The way to move through some of this is to find a way, which we have not done, to build in an incentive system where organizations can be sensitive to the population cost with much more flexibility underneath. The whole point of ACOs is the flexibility to have the delivery system deliver care without there's a bunch of other things. The 3-day rule. There's a gazillion of these little caps that are all put in place to prevent, I'm gonna use air quotes, which I really hate, overuse of care because they've experienced this dramatic growth in things. And too much of the American healthcare system incents use of a lot of care and then puts in administrative burdens to prevent it. So we're expensive and we drive everybody crazy. I don't know how, so I'd much rather have this debate about how do we get people into payment models that don't require us to come up with new codes for artificial intelligence algorithms, or just pick a gazillion, asynchronous telehealth communications for behavioral health. You could go through a whole litany of things that I would argue are really good things, but the payment model holds them back because they're worried about the fiscal implications.
That's really helpful. Thanks so much.
Great. Other questions here in the front? We have one. There's a mic coming. Maybe introduce yourself and then share your question.
My name's Cal Ernst. I'm a med student here. So you talked about Medicare Advantage being one of the primary avenues for innovation in that field. So my question is, you also mentioned that you're paying private insurers more than you would through Medicare proper. I guess a double-barreled question on that is like, where are the cost savings coming from that? And also, is there any incentive that you worry about with limiting care for people in those plans? Like incentivizing primary insurers or private insurers to not incentivize people to use care?
So the savings are coming by getting people not to use care. I think most of the evaluations of the quality of those plans is that the care across the board is comparable. In some cases, I could show you better, but certainly it doesn't seem worse. That I want to distinguish between the effects on average versus effects for specific patients or effects in specific MA plans. So when we talk about MA, there's a range of plans, just like everything. Some are good, not so much, right? But I think overall, the quality in MA tends to be better for a bunch of reasons. And they put in place a lot of prior auth. And so there's a lot of debate about the administrative burden and the appropriateness of prior auth. I think my general view of all of that is that the seminal work on geographic variation and even small area variation, like the original Wenberg work was like in Vermont, looking at the rates of procedures in small towns right next to each other. There's so much variation in the practice of medicine that there is room to reduce utilization of certain high-used procedures without that really being stinting on care. And so it is important that we do our best to measure the aspects of quality and to identify plans that might be providing substandard quality. And I think there's a lot of work, as I said before, that could be done in that space. But if you go into the conversation with the basic view, just let doctors practice medicine, and understand that I'm very sympathetic to the view, just let doctors practice medicine. It's a lot better than having economists practice medicine, and I think that'll get tweeted out somewhere, right? So doctors and clinicians should practice medicine. The problem is, without any system-level management or system-level incentives, you end up with wide variation and a ton of spending. So the plans, particularly the good plans, do a reasonable job of incenting. Sometimes they do it, for example, through partial cap or total cap, right? A delegated model, incenting or managing through utilization management, the use of care. And that's where they generate their savings. And so your question was whether I'm worried about the stinting of care. Very much so, but not to the point where I would say, okay, we should just, let's not interfere. Let's not manage. Let's not have MA. Because that's sort of, then I worry about overuse of care. I worry about the spending associated with that. So we do need to spend more time making sure that the care that's being delivered by organizations is good care. But it's hard to just take the plans out of the equation and just expect the delivery system to do that. And again, the quality of care in fee-for-service for people that have been involved, there's tons of problems in fee-for-service that Medicare Advantage can solve through data and other things. They can identify diabetes patients, make sure they're getting medicines. They can connect people to doctors. They can make sure they don't fall through the cracks. There's a lot of things the plans can do to provide better care that just doesn't happen in the fragmented fee-for-service system.
We'll turn to Kara Gavin to see if we have any questions from our live stream audience.
We do indeed, some great ones. Actually, one building on what you just said, someone just asked about variability in Medicare Advantage plans, and that health service researchers are limited by the data sets they can get at regarding Medicare Advantage because they don't have information about the plan type. And so how can there be greater granularity to understand this shift between fee-for-service and Medicare Advantage?
Well, there is now the Medicare Advantage encounter data, which is notoriously not the best data, although I do believe it's going to get better. So CMS is trying to release that, and you can connect that to the specific carrier and to the specific contract type. So you can identify which is an HMO, which is a PPO, and that type of thing. It's hard to get the exact benefit design, although again, in Medicare, you could find, if you matched up, Andy Ryan's not here, but if you matched up the plan traits, you can match them to the plans, you can match the patients to the plans, you can see what's going on. I think the bigger challenge is that, well, I shouldn't say the bigger challenge. Making sure that that data is better is a high priority, and it really took way too long to get access to that data. That I think is a fair comment. I think a bigger problem is how you use that data to adjust for case mix, for example, to understand are the good ones really good or the bad ones really bad, how stable are they, a bunch of questions like that. So data access, there's a lot of areas where I think we could get better data, and the MA data could absolutely be better. But I think they've made great strides, and I think that data will, in fact, get better.
One more?
And this one's near and dear to my heart, and that is this idea of researchers at places like U of M doing health services research on evaluating the impacts of policy or quality improvement efforts, but the significance of those findings is contained in journals, and how can they translate it to things that can actually reach policymakers?
Yeah. So, I spent a lot of time thinking about that, and actually I spent a lot of time in my role, because I know a bit about what's going on in the academic literature, trying to have that conversation. Again, I think there are certain people that are a natural at doing that, and so they just do it better. Mark would be an example of someone like that. And other people struggle when it goes out through journals. I think some of it is what happens through the press. Some of it is a lot of those articles may have an impact beyond what the actual researcher knows the impact is. And if you're lucky to be working in the right area at the right time, people will seek you out. If you happen to be doing, if you're studying Medicare Advantage, when Medicare Advantage becomes an important topic, my colleague Atima Rocha was studying telehealth. It was fine. People were interested in telehealth. COVID hit, and it was like, everyone needs to talk to Ativ. So a lot of it is a little serendipity about the area you're working and what the policymakers want. The one thing that I think I will say that's important to people that are interested in this topic, and others, Tom, others can jump in, is what I think researchers don't understand is policymakers are working in a very particular timeline, and there's very specific things that have their attention at a point in time. So it's not just what you've learned, it's when you've learned it and when they want to hear it. And so having the answer to the question they want when it happens to be a hot topic is important. And in some cases, you really have to find the policymakers or the industry voices or the other people that will amplify your message that will be sympathetic to your message. So if you want to support competition in healthcare, you got to figure out who are the organizations that would like competition in healthcare, who are the policymakers that would be amenable to this type of competition, how do we reach out to them? And just from that one particular case, and a lot of academics have influence in places like the FTC. So there's a lot of people we want to talk about Hill staffers, but a ton of the important ways that academic literature influences policy is through CBO, the Office of the Actuary, the FTC, ASPE, places where there are actually a lot of academics. They're familiar with the work that's being done, and that tends to reach out to policymakers. What doesn't reach policymakers sometimes is very micro. I get messages sometimes from people that I have a better way of treating, and they'll include a disease which I can't pronounce and sounds gross. And that's not unimportant. In fact, for a lot of people, that might be the most important thing. And for a lot of patients, that's incredibly important. Policymakers are rarely working at that level of micro activity.
Thanks. Did I see a question here and one in the back?
Well, thank you very, is it on? Yeah, thank you very much for being here today. My name is David Cantor. I'm a lecturer here at the Ross School, but my past history is 25 years working for Park Davis and Pfizer in R&D here. So my Medicare starts at age 65 and essentially has to deal with all of the abuses of health that have occurred in the 40 years prior to Medicare. If healthcare reform is significant for Medicare, what could Medicare do in the years preceding formal Medicare coverage that might change the cost or the efficiencies of actually delivering Medicare at age 65 and beyond? So for example, would a 5-year pre-Medicare period where certain interventions were put in place, would that be a policy that would have an impact?
So there's certain things that I need to think about on the plane. That's going to be a plane thought. But I'm going to answer you because I'm sitting up here and I feel like I'll be embarrassed if after Tom's introduction, how can I not answer you? But just so everyone at home knows, I don't know. The challenge with that line of thinking, and again, I spent a lot of my career trying to make sure people have access to high value, often preventive medications. Most of those things, for most people, are cost effective but not cost saving. So while there may be you could come up with an example if you do X, and I cannot tell you how many people have an example of the X. If you would only housing, food, screening for this, better treatment of blood pressure, better treatment of insulin, these are, more extra, there's a gazillion things, all of which, just to be clear, I'm very supportive of. It has been very hard to find the program that if you implement the program, you save money. Now, just as an aside, saving money should not be the goal of the healthcare system. The goal of the healthcare system is to keep people healthy. So there's a question about what should happen. There's a lot of public health. I spent 15 years in the School of Public Health. There's a lot of public health interventions that make people healthier. It's been very hard to find the ones that really save money. And to push Medicare into that there's a lot of reasons. There's a lot of debate about whether Medicare age should be raised or lowered. We have a whole separate conversation about that. But to have Medicare move under the age 65 in order to save money, just that motivation, and to do it through keeping people healthier when they're younger, my general response would be, let's start with trying to figure out the exact program that we think would really save money in general in Medicare. And again, I think there's a lot of things the government, that's not the same as Medicare, the government should do to try and keep people healthier. I don't think it's been easy to find those programs that actually save money long run for a bunch of reasons. And that's where the challenge is. If there was a clear cut, I don't know, David Mendez used to stop smoking, right? Getting people to stop smoking. I'm not sure how much that saves. It might save Medicare some money, according to Ken Warner and Dave. But anyway, the point remains, there's a longevity health status trade-off that makes that all complicated. But the broader point is, that's a reasonable thing to do. It's not clear that should be Medicare's job. It doesn't say it should be the government's job, but it's not clear that should be Medicare's job in the way that Medicare is set up.
I think I saw a question. Is there a question in the back?
Is that Dave?
Yes, David Butts, lecturer at Ross.
Been a long time.
Yes. So this is a question about MedPAC.
Okay.
Every year you put out this great report in March, advising Congress, and June, July, you put out these great reports, Medicare payment basics. We're in a period, I think, and feel free to disagree, of pretty stunning innovation and disruption. Some of it, things coming to a head, like the workforce not being as large as it needs to be. Others of it very hopeful. I guess my question is, what discretion do you have to sort of think long-term about what healthcare will look like in 5 years, whether payment models should be leaning into this disruption or accommodating it? So I guess the general question is, how do you think long-term about everything that's going on in the industry?
So yes, I wish 5 years was our long term. 5 years might be intermediate terms. But anyway, all that said, we do try and think long term. And I would say payment models are trying to think long term. The Medicare Advantage work, we try and think long run. I think to your question, let's see, should the payment models lean into disruption? Absolutely. In fact, my general view is the payment models should be flexible enough to enable efficient disruptions, better care, cheaper care, to move forward. And too often payment models have been impediments to that. In other words, you can keep people out of the hospital, that's great, except Now my revenue is getting people in the hospital, right? So I think it's been very challenging to have payment models that are more agnostic, that just kind of set a level of payment and allow the efficiency to happen underneath. And we do think about that. And I think in our alternative payment model chapter, not this year, but I think the year before, I'm not sure I'm going to get my years right, but basically tried to think forward about what I call the portfolio, Fender hates that term, what a portfolio of alternative payment models would look like to think about what Medicare would be. We're giving a lot of thought now. It's a shame this is sort of the end of the session, but to how Medicare Advantage should be structured in a world where there's not fee-for-service. So Medicare Advantage grows, you have less fee-for-service. Fee-for-service is benchmarking the rates. If you don't have fee-for-service, how do you mathematically set up Medicare Advantage? So we're thinking about competitive bidding, for example, which I actually am not sold on, but we're thinking about it. I think there's my general view, which I've been pushing, and again, people will hate, we can talk later, is what I call administrative benchmarks, which is more like what you see in other countries. You just pick the amount of money you can afford. You make people accountable for living within that budget. Now, of course, that could be too high or too low, which is the big challenge, but it's very flexible. The problem with competitive bidding, which again, as an economist, I like bidding in some ways, is it works when it's competitive. It's not clear that it always is competitive now. It's not clear it would be competitive if you let them start bidding. There's a lot of ways plans can manipulate the benchmarks if their bids are being used to create the benchmarks. So I think there is a lot of discretion to have that longer term vision. It tends to be big picture. How should we set Medicare benchmarks? How should we set ACO payment? It's less big when it comes to like delivery system organization. How should we think about consolidation or not consolidation? It struggles with how we should integrate telehealth. The delivery system process stuff turns out to be very hard to deal with at MedPAC, and I would argue very hard to deal in a policy space because it's so idiosyncratic to particularly the clinical area. And it's really hard. We've struggled with, I'll just pick another one, how to integrate Medicaid and Medicare in terms of post-acute care, where there's all kinds of complexities in how that plays out. And there's been a lot of demonstrations about how to manage that process, and there's these special needs plans. And it's not my area. So, but my understanding of people who understand it better, it's been a disappointing. Progress has been made, but it's been very challenging to figure out how to deal with that long-term structure of caring with people for people.
So, Mike, you fielded a lot of challenging questions in the past hour. I want to close our session with one that I hope is somewhat easier for you, and that is from your years living here and working here in Ann Arbor prior to 2006, and now coming back, what are some of the aspects of the University of Michigan and Ann Arbor that you've enjoyed the most when you lived and worked here?
Oh my God, that's a wonderful question. So that's so easy. You know, we came back in August, we were here and we were driving around with my wife, and I was answering that question then too. So I'll just talk about the university. And I've been at another university. The ability to have people in different disciplines work across the university is really better than most other places I know. And I would not be me if I had not started here, because I was able to come here in the School of Public Health, which itself is multidisciplinary. I had an appointment in the econ department, and the folks in the econ department were really wonderful. I was able to go over to the research seminars in internal medicine and learn how to say cholecystectomy just a bit. But the point is, I think it's very easy for policymakers, particularly economists, to not put enough appreciation of the underlying clinical factors that are going on to their detriment. I think it's also very possible for people in clinical settings to not understand like the fiscal pressures of what's going on and what the economics are, to why people are making decisions that seem like they're crazy. And I think being able to work across the university and in places like ISR where there's real data and other things that people do that are experts, and you can find survey experts, econometric experts, in anything you want, you could do that. And so just to be clear, there's other universities that have a lot of experts in a lot of areas. I think what's a little bit different at Michigan, at least in my understanding, is the extent to which they will be willing to talk to each other is probably well better than average, and willing to engage in those conversations, I think happens a little bit more fluidly at Michigan than it would at other places. And I think that's professionally what I think I've liked most about Ann Arbor. And again, as someone who started her career here, I would be remiss if I didn't say it was, by and large, particularly for junior faculty, a really supportive place. for people, and I think that actually matters a lot. In terms of the town of Ann Arbor, I barely am out of my driveway. I used to be able to park, get to my house to park before now I can barely get out of my neighborhood. So it's just a much more, it's a nice place to be. It's an easier place to live than a lot of other places where people might live. And so we really, enjoyed our time here. I don't know. I can't compliment it. I mean, told to quit complimenting Ann Arbor. That's a sign. Anyway, thank you.
Well, thank you, Mike. And your comments about the spirit of interdisciplinary collaboration here and building a culture that's strong for early career faculty and sustaining their careers and their excellence. That's a big part of our organization, the Institute for Healthcare Policy and Innovation, and the spirit of what we try to do here at the University of Michigan. So on behalf of all the faculty, staff, learners within the Institute, those of you joining us here in person as well as on the live stream, please join me in thanking Professor Mike Chernew for speaking with us today and sharing his insights.
Thank you.